There are many avenues that we can essentially explore from a data perspective, and Research Australia has had a long-term focus on ensuring that health and medical researchers can essentially harness that, what we call the transformative power of data to accelerate advances in health. Now, health data remains, to some extent, an untapped national resource for Australia, although we are making some slow progress in electronic medical records and a better access regime through the newish National Data Commissioner. And as I said, we're going to talk a little bit more about the Australian context in a while. But first, let's hear from the man of the hour, Professor Andrew Morris. It's wonderful that you've made it to Australia, and even better that you're going to share your lived experience with us today. And for those of you who don't already know, Professor Morris has been working in this area for many years and is, of course, very appropriately credentialed to discuss the complexities as well as the advancements that have been made in the UK context. Now, I'll touch on a few of the roles because, as you can well appreciate, Professor Morris's CV is extensive. But importantly, Andrew, you became the inaugural Director of Health Data Research UK in August 2017, and that means that you were seconded from your position as Professor of Medicine and Vice Principal of Data Science at the University of Edinburgh. Prior to this, you were Dean of Medicine at the University of Dundee and Chief Scientist at the Scottish Government Health Directorate. Your research interests span informatics, chronic diseases, and in 2007, you co-founded Iridia Informatics, which uses, surprise, surprise, high-performance computing and analytics in healthcare. And you were awarded a CBE in 2018. I think we are very excited to hear from you. So without further ado, welcome, Andrew, and over to you.
Well, Nadia, what a huge pleasure to be in Australia. I've come at a very good time because it's the only time in the last 40 years that Scotland have been above Australia in the world rugby rankings. So thank you for that. So it's good
That's
time.
a cheeky shot.
A cheeky shot. So I'm just going to try and share my screen. Can you see that?
Yes, we can. Thank you.
Okay, and I'll canter through this. And it's great to be online with Greg. And also, can I thank Christine and the team for supporting my visit to this most wonderful country. So today I'm going to talk about the convergence of care and research and suggest that because we're at an inflection point in biomedical discovery, in health system design and delivery, but also about the fundamental sustainability of health systems. And that unless we encourage a convergence of care and research underpinned by data science, patients, populations will not benefit. So that's what I'm going to try and talk about. So the next, and I'll canter through this because we had a few technical issues. So I'll talk about the pace of change, talk about national scale, and try to convince you that it's really important that sometimes we take our institutional hats off and work nationally and internationally. And lastly, say the opportunities are endless. It's time to be bold, ambitious, and enterprising. And can I thank the organizations who have done a whistle-stop tour of Australia? It's been wonderful, but who've supported my visit. But also suggest that Research Australia has a key role here. I took this is your mission statement. You have a unique convening power. You want to position health and medical research as a significant driver of health and economic growth. And I would argue that without a data strategy, you'll be challenged to deliver on that objective. So let's talk about the pace of change. Firstly, the denominator, the global population. So I was born in 1964. As you can see, there were 3.6 billion people on the planet. As of last November, the UN estimate that there were 8 billion people. So in my lifetime, the pace of change of global population growth has been phenomenal. And what we've seen with that is a pace of change, sadly, in health inequalities. They're getting worse. And how do we address inequalities so that we meet the 6 dimensions of quality healthcare, one of which is equity? So I just want to talk about the pace of change. Now, this is a funny picture, but this was me in the ward in Glasgow in Scotland in 1987. And you shouldn't sit on the bed, as you know, in hospitals. So as you can see, I was sitting on the bed. And I remember the patient's name was Esther McCulloch. But it was Bill Gates who said, people overestimate what they can achieve in a year and completely underestimate what they can achieve in 10 years. And everyone on this call could do the next sequence of slides for their professional career. Because what did we not have? The Glasgow Coma Scale. This was data science for phenotypic measurements which predicted outcome of head injury. Well, we didn't have MRIs. We didn't have MRIs to 1984. Statins we didn't have to 1986. Now 400 million people globally on statins. Laparoscopic surgery didn't come along till 1990. And I say this slide always explains why you can never find a surgeon in a hospital, because they're all in the same place. Smoking ban in public places, and more recently, immunotherapy. So we're seeing a rapid pace of change, even in our professional lives. And the argument I'm making is that that pace will only increase. And if you go to, this is on the right-hand side of the slide, sadly, that's not Scotland, that's actually Davos in Switzerland. As you know, the World Economic Forum goes there once a year. They talk about the fourth industrial revolution, because we're seeing a fusion of biology with physical sciences, computational sciences, and social sciences. And it's changing society. Why is it? Because it's happening in every country, in every industry vertical. Secondly, the pace of change is exponential rather than visible. This is the death of the high street in the UK. And lastly, it is very disruptive. And it's even, as you know, undermining democratic principles. So I consider that the fourth industrial revolution is coming to our world, and it's up to us, domain expertise, to ensure that we apply it in a trustworthy way. Because if you look at technologies, so in my world, we do diabetes, we do cardiology, we do renal medicine. This is computational science. And what we've seen in the last 15 years is two things. Firstly, not only remarkable exponential progress in the subdisciplines of computation, whether it's sensors, robotics, natural language processing, but also a confluence of these technologies into products. And the pace of that is remarkable. At the bottom, you'll see the Internet of Things will have almost 30 billion devices connected to it in 2030. So here's another example. This is one of our many former prime ministers, you can see on the left-hand side, being shown around a supercomputer. It happens to be at the University of Edinburgh. So we're deploying Exascale, which is 1 billion computations per second. And many of you will be familiar with ChatGPT. I usually say, who's not used ChatGPT? We all have. But if you look at the rate of uptake, firstly, for 1 million users, so Spotify, which I think we all probably use, took 150 days to get 1 million users. It took ChatGPT 5 days. And the scale is remarkable. So as you know, ChatGPT had about 175 billion parameters in the input. ChatGPT-4 has 170 trillion parameters actually engaged in the unsupervised learning of large language models. So scale is going to be important. And I think that's why one should consider, national scale infrastructure. Another illustration in our world, this is the relationship of blood pressure and mortality from 5,000 people, the Framingham study. That's 50,000 people. That's UK Biobank. So scale is going to become increasingly important. So what we're seeing is the opportunity for health data science to support 4P medicine, medicine that's predictive, preemptive, personalized, and participatory. And that will be enabled by genomics, phenotyping, informatics, and analytics. Detail and scale are important. But also, we've got to consider geopolitical concerns as well. And context is important. So I also talk about 4P society, which sadly is Putin, pandemic, public sector unrest, and pressure of inflation. And I don't know what it's like in Australia, but I sense that the pressure to provide better quality care at reduced cost and to demonstrate value of the research pound is coming into focus. So this is an OECD graph showing the countries in the world that are on the cusp of adopting health data science. So this isn't my data, it's OECD data. And as you can see, they rank Australia sort of mid-table on technical and operational readiness. but they say that data governance readiness is actually low in terms of systems to access data. They currently cluster the UK up here in the sort of upper right quadrant. So I think there's an opportunity for Australia to think, how do we look at our technical infrastructure plus governance infrastructure to drive change? Because when you look at international best practice, and this is some old data, but looking at high-performing health systems globally, they not only focus on quality, have good integration across primary, secondary, tertiary care, have a real focus on primary care, have strong medical and managerial leadership, they also have data as infrastructure in near real time at the population level, at the meso level to allow you to stratify care and need across the population, and at the micro level for patient management. And a framing I'd like to suggest is if we get this platform as a service or data as infrastructure right, we can optimize care, we can perform population health management, service planning, we can augment clinical trials and underpin R&D through a common platform. And we sort of did that in Scotland. So this is the new official map of Scotland. And this is where I sort of grew up, because in the early days, we recognized that because of a unique patient identifier for health, we could link data. And this isn't rocket science, but this is the healthcare system many patients sadly have to negotiate, completely fragmented. And if we link data, it's vital for seamless care. And in the early days, we linked data initially for diabetes, but then for other diseases. And then we wrapped the wrapper of education, training, guidelines, standards, delivery plans. We did that for diabetes, and we've been doing it for the last 25 years in Scotland. There are now 376,000 people living with diabetes in Scotland. We underpinned it by whole system intelligence that weaves together the journeys of care. And what we saw within 4 years was a reduction in amputations and blindness by 40%. So it's a way of, it wasn't hard. You know, Ed Wagner, the chronic care model from Seattle, really framed it. But it works, because otherwise patients fall between the gaps in the care system. So what is this inflection point? You know, I think that classically on the left-hand side of the screen, we've relied too much on a one-to-one relationships. You know, I might know Greg and he's got a data set, and I said, let's do a bit of collaboration. Can we make data secure and confidential, but fair? Findable, accessible, interoperable, reusable at scale, so that we have a many-to-many ecosystem, because then you can drive quality improvement, health service planning, optimization of care, research and development. But if you look at other data ecosystems, they need a set of tools, protocols, standards, governance to allow that to happen. And that's what HDR UK does. We don't want to control data, but what we do want to do is drive the frictionless activity of this data ecosystem. So that's what we were charged to do. It was pretty bold at the time, but we set up 5 years ago, and all credit to our funders. So 10 funders came together. So folk like British Heart Foundation, Medical Research Council, across the UK to say, instead of having subscale funded competitive programs, can we do this well and once for the UK? So our mission is to unite the UK's health data to enable discoveries that improve people's lives. And health data is health relevant data, and I'll touch upon that. But we're now running studies on 68 million people, which is the population of the UK. And all credit to our funders, they set us up. It was prescient in advance of the fourth industrial revolution. And in terms of the money, just to give you an idea, our core was initially about 50 million pounds. We leveraged another 120 plus 100 in kind. So we're about 250 million for the UK. And we've had support from Gates, from Minderoo and others to do this. So that's the thesis. How do we do it? We have a triple aim. We want to do 3 things: accelerate trustworthy data use, empower researchers, innovators, and analysts, and promote partnerships. And the third is most important because not one sector can deliver this themselves, whether you're government, whether you're a health service provider, whether you're academia, industry. So it arguably does require a new set of relationships across the delivery partners. Our structure is that we are institutionally agnostic. So we're a charity, because if we put this in Oxford, Cambridge, or Edinburgh, you'd have immediate distrust in the system. So we sit in the Wellcome Trust in London. We have a strong independent board of various folk with strong industry, ethical, academia, NHS, behavioral science expertise. And over the first 5 years, we've recruited 86 organizations across 32 locations, and we've spent a lot of time on the operational machinery. And we now have a single contract that covers engagement across all those organizations, whether they're universities, other public sector bodies, or the NHS. And we've got a wide distributed leadership team across the UK, because this is team science at scale. It's about coordination and connectivity, not command and control. So in the early days, I said, well, we better map the ecosystem. And the team went away and did it. And when they showed me this, I had a stiff drink, because I thought, blimey, how are we going to bring that together? But then, I went to Holland recently. They look just the same. So, and Australia will look just the same. And I would suggest that countries which are going to do this well will be able to address the connectivity and coordination across these multiple entities. And if you do that, you achieve this. You get, as I suggested earlier, diverse data, data at scale, but most importantly, it's longitudinal data, so that you have exposure and outcome over time. And what we're currently doing is trying to map that for the entire population of the UK. I talked about the how, and we take values very important, because a lot of this is a bit countercultural or challenges current misaligned incentives in the system. So we're very big on values: transparency, optimism, respect, courage, and humility, because this is not command and controlled in heroic leadership. One is trying to convene across common purpose, then introduce common protocols and standards. So I'll just now, if I've got time, to go into a bit of detail in each of the three buckets. So firstly, accelerate data use. Funders often hate paying for infrastructure, but actually data is infrastructure. And what we did was map out the components of a well-governed and a highly performed infrastructure. And we actually modeled it on Amazon, which the Amazon marketplace connects content providers with consumers. And what we want to do is connect data assets with researchers and innovators. But to do that, you need various components. So we have an alliance, which is a bit like Research Australia, really. We have a gateway, which is a technical platform, which puts all our data to ensure it's fair. Then we have the tech stack, the governance, the standards, the capacity building. So it's really teasing out each of the services which contribute to a trustworthy data ecosystem. And in terms of the alliance, we've got about 80 members across the UK, NHS, universities, etc., who all subscribe to fair data. We've got a gateway. We've got leadership in public engagement, involvement, governance and ethics and capacity. So it's work streams of science of the infrastructure. So this is our gateway, and anyone in the world can search metadata on UK data sets. It's all there, and then request access. And we've also, I said there was a sort of technology ecosystem. Rather than data travel across the system, because confidentiality and privacy are key, we've embraced this notion of 5 safes: safe people, safe projects, safe settings, safe data, safe outputs. And it's a way of providing assurance and safeguard to the publics that we are handling data in a very secure way. So these are emerging into sort of multi-tenant project spaces in a cloud environment with project-specific workspaces and audit. So this notion of secure data environments is important. And through our collaboration with the NHS, they've just put £270 million into these nationally, basically, to have a trials secure data environment, a national secure data environment, then regional secure data environments. And each region would be about the size of Victoria or Queensland or New South Wales. So what you can see here is the investment going into England-wide secure data environments, which complement the ones which already exist in Wales, Scotland, and Northern Ireland. And what we're doing is, in a very transparent way, saying how well are we doing in filling the data tapestry. So as you can, sorry about the small type, but you can see for demographics, we've got data on 54 million people, for primary care data, about 40 million, prescribing, etc. And this will mature over time as we weave together the data estate. Training is important to us, and we maybe touch upon that. We talk about training being T-shaped. Yes, we want the future leaders, but we also want to make health data science and data science literacy as broad as possible. So really trying to provide a curriculum opportunities for everyone. And one good example of that is our Black Internship Program, because equality, diversity, inclusion is important. So we specifically launched a program 4 years ago for Black interns, and it has been fantastic. We've uncovered capability, expertise, and future leaders in this previously neglected members of the community. And actually, we have evidence now that many of their careers have been accelerated working in places like Imperial, Oxford, Cambridge. So you can use data science in very creative ways. How do we involve the public? Significantly. So we have a public advisory board who listen, advise, and hold our feet to the fire on everything we do. So we weave public engagement into everything we do, so that we have a dialogue with the publics, especially around sensitive issues. For example, industry access to data. You know, those knotty issues that we don't have the answers on. And that was particularly prevalent during COVID. The other thing about public engagement, it is not a one-off thing. Government often says, oh, we'll spend £2 million on it and it's done. So we weave public engagement and deliberation as a continuous theme of the Institute. And one example here is colleagues in London, because London is now running studies on 10 million people who've created behavioral science approaches to engaging the public across London, including citizens' juries, including taking 100 citizens away for 4 days to consult on health data science. And I think this is really important stuff. And then finally, I talked about governance and access. So this is Cassie, who's former legal counsel for Amazon, who's now doing health data science. And she's great because she's a lawyer who likes solutions rather than saying no. But what Cassie has done is try to address this knotty issue of access, data access. There are some PhD students were waiting 3 years for data, which is just nonsense. So what Cassie has done is create a UK-wide governance steering group. Ethics, the law is interesting. There's really creative stuff we can do in this space. And what Cassie has done has started to bring together harmonized approaches to data access through a legal toolkit, from mapping of data sets, from automating the 5 safes in terms of accreditation, authorization of researchers, in terms of what is safe data, etc. Also at looking at international data access. So the second piece of the puzzle is empowering researchers, and that's about data. Researchers like data. So we have various buckets. So we have nationwide data, we have regional data, we have non-NHS data like education, disability, etc. Research-generated data sets, environmental and personal monitoring. And these all contribute to the data tapestry. And what we're trying to do is curate this at scale for the whole of the UK. And the approach is, rather than build it and they will come, because you might build the wrong thing, and I frequently have, is to say, how would you get the user to help shape the infrastructure? So we have this notion that we stole from the Global Alliance for Genomics Health called driver programs. And we have and these were our first 6, but just to illustrate, what is a driver program? It does 2 things. Firstly, it does science at UK scale. So science that individual PIs or institutions can't do themselves, but also it cleans the pipes of the infrastructure, whether it's the standards, the compute in the cloud, the governance. So you leave a legacy for someone else. And finally, we promote partnerships, and we've got the notion of regional partnerships, but also global partnerships. You know, in the pandemic, we worked with across 19 countries, because many of the issues of data engineering, data access, data governance, infrastructure are the same everywhere. So how could we work in partnership? And I was saying yesterday, there was a fantastic collaborator from Melbourne who helped us curate a birth data asset of 25 million births during the pandemic across 60 countries to look at the impact of COVID on perinatal morbidity and mortality. So the future vision is to work in partnership with similar national biomedical informatics institutes to run experiments at scale. And we'll need that for the next pandemic. I talked about the regions, and this is the iCODA stuff that was funded by Minderoo, thank you, Mr. Forrest, and the Gates Foundation. But again, we have an enabling role. We want research to be easier wherever researchers reside. So that's the sort of theory. In the last probably about 8 minutes to go, I'll just tell you how it's going. Because we're still in the foothills of where we need to be, and we've made a lot of mistakes along the way. But you know, we specifically support about 500 projects. This is slightly out of date, this slide, apologies. So it's a bit more than that. We've got about 90 members of our alliance. We've got data research hubs. We've got 800 data sets, and that has enabled the researchers like it. So it's enabled 3,500 people with about 151,000 citations. So that's the usual academic metrics. But I say we need products as well as papers. So we'll touch upon that. And that's how our citations are increasing. And then we did some visualization. This was a sort of cloud of collaboration. So that's what our community was publishing in 2018. And you can see how they've come together in terms of team science. Just to give you 2 of the driver programs in a little of detail. So medicines, in the UK, we spend 26 billion pounds a year on medicines, but actually harm associated with medicines costs 1.6 billion pounds, because we need to look at safety as well as effectiveness. So Mania and Liz are leading a UK-wide program to look at adverse drug reactions and aiming to cut ADRs by 20% across the UK so that we reduce the harm and the cost. And they've got a great track record of doing this. But to do that, you need data as infrastructure. So we're pulling together a national map of medicines use across the UK. And in the pandemic, we managed to achieve that. So we've now got about 40 billion rows of prescribing, which we can now map to outcomes. Here's an example of how Richa Soffit and colleagues were looking at safety of valproate in pregnancy and feeding back to appropriate or less appropriate use of valproate. And this was something in Nature Medicine a few months ago. Nationally, again, showing how nationally medicines for cardiovascular disease fell off a cliff in the pandemic and led to 20,000. So it's trying to take these big chunky issues at a national level. Another example is John Dinesh and Sarah Lungton. So this is Oxford and Cambridge working together, putting all the multi-omic cohorts in the UK together with electronic health records. So we've got quite a lot of data in the UK, human-based, that links RNA, protein, lipid, lipoprotein data with outcomes as derived from electronic health records. And open science is a key theme. So they've published the polygenic risk score catalog, and we've just published on the omic spread catalog, which is an atlas of genetic scores for predictions from multi-omics data. So it gives you an idea. I'll skip on. And you can't come to a meeting without mentioning COVID. So what did we do in COVID? Patrick Vallance, who's our chief scientific advisor, said, we need to look at COVID data on the national scale. So we were asked to map the data, sort the infrastructure and services, and then enable research at scale. So just 2 slides. This is a busy slide, but it shows the sort of data map in June 2020 for England, Scotland, Wales, and Northern Ireland. And what we were able to do is to mature it into that about 14 months later. And it wasn't just primary care, genomic data, vaccine data. It was also stuff like labor force data, business impact, COVID opinions. So you start to get that tapestry, which is cross-sectoral. And that was really powerful. This was within 6 weeks of the vaccines being rolled out in the UK. Aziz Sheikh and colleagues were able to determine vaccine effectiveness of single-dose AZ and Pfizer-BioNTech. And that led to an immediate change in policy because there was an 86% reduction in hospitalization. And that allowed us to stretch out dosing interval, because in those days, we had insufficient vaccine. So that was an example. And the teams across the UK did that for vaccine effectiveness, differential effects of variants. So we were able to show that Omicron was far more infectious, but actually had less morbidity associated with vaccine waning, which we did. So you get this sort of idea. We also look at risks. This is a study on 56 million people in England, looking at thromboses associated with vaccines plus COVID, because it was a trigger which was inducing vaccine hesitancy in the population. And we were able to show across 48 million people for these rare events, the absolute risk of these major venous and arterial events. And you can follow people up. We talk about long COVID, but how long is long? So again, a study on 48 million people showing the residual cardiovascular risk post-COVID infection. And this must have been important because it made it to the Sun, our best medical journal. So aftershock, urgent warning, who's had that deadly complication. I talked about augmentation of trials, and you may have heard of the recovery trial, which recruited 46,000 people for repurposing of agents in COVID. The key about the recovery trial was the ascertainment of outcomes was through routine data. So taking data already collected across the UK, Marion Maffam and colleagues and Martin Landry, our research directors, were able to change the way that the ascertainment of events occurred. And we're now seeing this approach being mapped into other clinical trials. So health data research was higher up in the media agenda. And there was a lot of press coverage of this type of stuff, even in Portuguese, as you can see. So with our driver programs, I've talked about medicines, I've talked about respiratory cancer, cardiovascularly. We're now taking this same approach to non-COVID related harm. And we're also doing it much closer with industry. So this is a program looking at neurodegeneration that's brought together Eisai, universities, LifeArc, Gates, and ourselves to create data as infrastructure and neurodegenerative spine for the UK. Also incorporating new data types like voice, nationwide imaging data, and nationwide retinal screening data. So you sort of get the idea. And this part of that program. This is Pierce from Moorfields. He's wonderful. So he was in Nature 3 weeks ago because we took OCT data, 1.4 million OCT images, and then linked the data And it hit Nature because through OCT, unsupervised learning on retinal images, he was able to predict Parkinson's disease 7 years before it was clinically diagnosed. So it gives you an idea of the potential. So finally, it's time to think, how can we shape up to be bold, ambitious, and enterprising? Because trends, healthcare is completely ripe for disruption, and we're seeing that, tech companies are becoming very engaged following the acceleration of health data science that we saw with COVID. So this is going to happen. And I think it's about countries being well positioned to take advantage of this major focus, major investment in a trustworthy way for the benefits of patients. We're going to see a movement to, instead of treatment, more towards predict, protect, and prevent using multimodal data. And we're going to see it across the domains of synthetic biology, genetics. But to do it, you need detail and data as infrastructure. If AI is going to land, you're going to need high quality data. So digitization is here to stay, and just this is to emphasize the amount of venture money that's going into this space. But I think what we will see is venture going to data ecosystems where there's quality data. We're starting to see it in places like the West Coast of America, UCSF, which are applying ChatGPT to the delivery of sort of mundane activities within their health systems, like summarizing patient notes and stuff like that. So a few thoughts, Nadia, to conclude. Can we pioneer health data science in Australia and the UK to do these things? Optimize care, deliver population-based management, augment trials, manage the health service, and drive research for public benefit. To do that requires collaboration. And, I was at CSIRO the other day. It was fantastic. There's lots of stuff here I'd like to take home with me, and we will. So how do we collaborate at scale so that we bring these skills together? Math, statistics, computation, ethics, the law, biomedical research. And can we, through our networks, accelerate a nationwide trustworthy data as infrastructure across public health, research, and innovation in Australia? So this is a 20-year play. It's a bit like the initial Human Genome Project. It took 20 years. I see it the same. It's a 20-year play. But one never notices what has been done. One can only see what remains to be done. If I'd said 5 years ago in the UK, we'll be running studies on 68 million people, people would have laughed at me. But we're doing it. We now just need to look at the resolution and the breadth of data. The new Einstein, this does challenge research culture. There are a lot of misaligned incentives. People get promoted on the basis of their Nature paper, whereas actually we're working with the funders to say team science needs rewarded, especially for the folk who do the data engineering, the curation, the management, because they drive and enable. And finally, we had a lot of bumps in the road. An early bump on the road was when we were thinking we need a brand. So we came up with HDR UK, but sadly we saw that Havering Demolition and Recycling had stolen our moniker. So we had to send them a crate of beer to try to allow to take the domain name off them. So you will have bumps on the road as you try to achieve it. So Nadia, team, it's a real pleasure to be in Australia. And I think the opportunities here are completely endless, except on the rugby pitch. So I'll stop there.
Andrew, thank you. We'll have a chat afterwards about your rugby support, but for now, let's stay on topic. As Jason pointed out, tons of wisdom in that presentation, and thank you very much indeed. Now, I know that I'm going to let's start the discussion, and Greg, and then we're going to come to you and have a bit of a walkthrough from the Australian perspective, and then take the discussion specifically into the Australian landscape. But you talk about 5 years ago it was a bold move. Would it still be a bold move if you were starting today? Do you think attitudes would still be the same?
I think the pandemic acted as an accelerator. And, you know, I say there was more, you know, we have, in the UK, we have News at 10 from the BBC. There was more health data news every night on that program than there was sports news. And that was unimaginable. So I think the awareness of the importance of data, whole system intelligence, being able to create evidence is much greater in the public persona than it was 5 years ago. So I do think it's a good time.
I mean, I suppose the other, and I'm going to ask us, and then I am going to open it to the floor. So I'm going to say, anybody who has typed their question, and if you want to ask your question, please just raise your hand. I'll come straight to you. Otherwise, I'll ask it on your behalf. Andrew, you talk about it being a 20-year mission. Given the exponential growth of technology and in particular infrastructure, can we afford such long view looks in this case? Because 20 years, it seems like everything you're doing now will be out of date.
Yeah. So I think the mission is 20 years. The tools, the technologies will change, and we're seeing that. One of our principles is to be agile and flexible, to be able to, but I think that the mission and the vision are for 20 years, because I'm a doctor, and, it pains me that there are, post-pandemic, 7 million people waiting for treatment, and that some of them have pretty profound diagnoses of cancer, cardiovascular, neurodegeneration. So if we can harness the tools that we have and that are emergent to drive quality of healthcare, and that includes timely healthcare as well as safe, effective, equitable healthcare and efficient healthcare, then I think that mission will remain unchanged. How we do it, we just need to be agile and take the best tools for the job, and that will change. The analogy I use is genomic sequencing. I don't have any biomedical scientists. 20 years ago, we all had an ABI sequencer at the end of the bench. We all did it ourselves. You wouldn't do it now. You send it to Illumina. So, but we still...
How things have changed.
Yeah.
I'm going to go to Chris from the Childhood Dementia Initiative.
Hi, Andrew. Great talk. Really interesting. Thank you. So childhood dementia is caused by 140 plus genetic rare diseases. And I just wondered if you had any insight into how rare disease data can be captured, given that identifying rare disease patients in health systems is difficult with the current coding systems.
And I didn't drill into data quality, but an element of data quality is data availability. So as you suggest, Chris, some of our routine data systems are just too high level or insensitive to collect the resolution of data that we require. One of the key facets of the data ecosystem, it has a low barrier to entry and a level playing field. So, for example, we are working with, I don't know, you're probably aware of Genomics England and the Developmental Disorders Initiative, which are very deep research data sets, which actually have the resolution that you're talking about. But the ability for those to link automatically to longer term outcomes adds value to those data assets. So that's why this will not always be a sort of routine, we need to unleash the power of both research data sets as well as routinely collected data sets.
Nadia Badawi, I'm going to come to you now because I suspect your question is linked, given Cerebral Palsy Alliance. So the floor is yours.
Yeah, thanks, Andrew, and thanks for your good humor yesterday at the Health Awards. But I suppose I worry about the children and babies' data. They have the most to gain, but also we worry about their privacy. Governments worry about their privacy.
Mm-hmm.
I think they need a special look and just something. Do you have any wisdom here?
So, well, maybe to ask you, because we set a very high bar for all data and regard it as being sensitive. So, and I enjoyed your company last night very much. I hope you won the prize, by the way.
Oh, we did, surprisingly.
Well, I voted for you. So, but in terms of in terms of specific needs of that very important population group, what additional safeguards do you think is merited?
I suppose I worry that they have not consented. Adults, by implication, have consented. Children haven't. And then we know that, unfortunately, insurance companies are hovering to try and take rights away from people. Employers, you know, it's just very difficult. We're not sure what to do, and we'd love to see how the governments could embark on this.
Now, the word consent is key to this, but consent is and I've spent a lot of time in the company of lawyers, and actually I've learned a lot about consent, human rights, duty of confidentiality, and data protection. Consent is part of the equation, but we would not be able to run the studies that we do if we required consent on 68 million people. So we use a blend of consent, authorization, anonymization, with these parallel safeguards in the system to ensure privacy, confidentiality, and security. And the legal basis for the analysis for a lot of our studies is on the public benefit test, which is part of the GDPR, that one can use data for the public benefit. Because we feel that if we went down on a consent-only basis, some of the most marginalized parts of society would be likely to be disadvantaged even more. Because
I completely agree. And but anyway, it's something I don't want to hijack the whole talk about, because it is problematic, and we have a lot of opt-out data sets.
Yeah.
Thanks.
All right, Nina Matthews, coming to you. A collection of data with the use of smart devices.
First of all, thank you, Andrew. Great talk. Really enjoyed it. I noticed that one of your slides had a small mention of personal devices for data collection, and I was interested in that because obviously there are a lot of users today of smartwatches, smart rings, Fitbits. Do you have a plan how you would collect the data? Would it be a citizen science kind of approach, or would it be clinician driven?
Good question. And again, this goes back to Nadia's comments about, you know, if you're too fixed, your vision or your tools will be out of date in 20 years' time. Because I predict in the 10 to 15 year time frame, most of our personal clinical data will be on devices, and we'll be deriving a lot more data from wearables and sensors. So this is where the puck is going, if they say. So we've got 2 or 3 research programs into this, led by people like Tim Chico here in Sheffield and Richard Dobson in London. And we're also working with the device companies such as Verily, who, as you know, are the life sciences arm of Google, because they're sitting on all these data, but in many ways it can't be leveraged unless you can link it to the outcomes data that we hold. So we're working through novel public-private partnerships to leverage these data. Probably the best example was in the pandemic. We had something called the Zoe app. I don't know if you heard of that, which was a self-reporting app of COVID symptoms, which actually it was a little SME in London, a small medium enterprise. And they phoned me up and we said, we've got data on 5 million people. Everyone's asking us to use it. How do we do that? So we took that industry data set to within one of our secure data environments, and 70 research groups used it to actually look at symptoms as was derived from a handheld app through to outcomes. And that was, that was a nice case study. That was like a driver project, which told us how to do it.
We're going to move now to a question from Jim Mackey and then a follow-up question from Dr. Jason Jin. And the first part of the question is, do you have a mechanism for engaging with local clinical teams who are the usual drivers of implementation and improvement? And the related question to that is, what role do you see medical professionals playing in the acceleration of health data infrastructure? Shall clinician scientists be in the driver's seat for the change, or are they advisors rather?
So good questions, Jim. So again, I use the phrase build it and they will come is the wrong approach. So it's about user-centered design. So we weave, especially in the sort of better care program of optimization of care, population stratification, and health service planning. We work hand in glove with the clinical teams because they're the users, and our job is to enable and provide the tools to make their lives easier. So yes, we have very, very close engagement. On these regional network calls, they're all clinicians supported by data scientists. So getting that chemistry right is important. Secondly, the role of clinicians. So I think we're probably 15 years behind the States, because if you go to the States, you can train in a profession like renal medicine and cardiology and informatics. And if you go to somewhere like Vanderbilt, they have a chief clinical informatics officer. They have a chief nursing informatics officer so that's that clinical leadership, which actually identifies the potential utility and co-creates the solution. So if this is purely a technology game and technology creep, we fail. So it is about creating those teams and respect amongst those teams. So I don't know, what do you think, Jim?
I'm going to move us on, Andrew. One of the large, and perhaps Jim will come back in on the chat, a question from Annette Dobson, and I'm going to take this question, and then we're going to do a very quick walkthrough of the Australian context and then come back into the chat. So questions that are there we'll continue to ask and obviously encourage more from the floor, specifically on an Australian context, but of course not limited to. So Annette Dobson asks and says, one of the largest gaps in accessible health data here is GP records. To what extent have you been able to drive major structural changes such as GP funding mechanisms?
Okay, so that's a good question. We could have a whole day seminar on that.
And there's some funding questions that we're going to touch on, I think, in the second part of the chat, but let's take this one. It's a good one.
The GP, and to be honest, there's been knotty issues around GP data. It's been used as a bit of a lever and a bit political. So again, we approach it through patient benefit. In the pandemic, we had access to GP data for the whole of the UK. Some of those agreements are being reviewed at the moment. There was a very innovative approach called Open Safely, which looked at a research and analysis capability upon the GP data set. So there are irons in the fire. Primary care data, however, are absolutely essential if we're going to be able to do risk stratification. And again, we take the approach that to make progress, it's really important that we understand the user needs of the GP community and try and make their lives easier, so that they rather than it seem being a one-way flow of data or value, you've got to feed value back to the clinical community. So that's our approach.
Yeah, I'm so tempted to dip into the how on this, but in the interests of time, we'll keep on moving. Well, what I'd like to do is just pause for a moment. As I said, we will come back to the discussion. I'm going to ask, Research Australia's Head of Policy, Greg Mullins, to give us a quick update on health data progress in the Australian context, because I think it's an important lens to have as we talk about what an Australian version of Health Data Research UK might look like. So, Greg, we'll have the whistle-stop tour, please.
Thanks, Nadia. So, yeah, look, we've heard about what's happening in the UK, and I'm going to try and provide some context on health data for research in Australia and perhaps how it might relate to what we're seeing in the UK. So, look, the My Health Record is the National Electronic Medical Record. It was first implemented more than 10 years ago. It's really failed to gain traction, and the underlying IT platform's now being replaced, which is slowing things down. Its use is slowly expanding, with more data now being added by default. There was a framework for the secondary use of data for research purposes that was developed several years ago, but no data has been released for research under that framework. And of course, there are numerous other state and health provider-specific EMRs used in Australia, as well as the Medicare and PBS databases and immunisation registers. And we did see some moves during the pandemic at the government level for them to combine some Commonwealth and state databases for data sharing, but that really hasn't come out to researchers. It was used for the purposes of building things like the vaccine registers and those kind of things. So yeah, some progress there, but it has slowed. This leads on, I think, to the Office of the National Data Commissioner. So the ONDC is still a relatively new agency, and much of the work to make the Act operational is still in progress. The Act was only passed in early 2022. It's actually intended to facilitate secure access by researchers at universities to Australian government data assets, such as in Medicare and PBS, and to implement standard data sharing agreements and a single searchable data catalogue. So some of the things we've been hearing about from Andrew. As of yesterday, however, no university has yet been accredited as a data user, which is a prerequisite to being able to access data under the scheme. So things are certainly moving very slowly there. The Australian Institute for Health and Welfare has been around for a lot longer. It's one of the key elements, I think, in Australia when we think about data. Produces a range of reports on expenditure in our health system, on disease trends, prevalence, and other matters. But most of the data it produces is at an aggregate level. It's also the data custodian for the My Health Record and would be involved in data sharing there. But it's a role which really hasn't gone anywhere yet because no data has been shared to date. So, some scope, but not much action. The Australian Research Data Commons is funded by Australian government under NCRES, so the Collaborative Research Infrastructure Scheme. It really aims to drive the development of national digital research infrastructure that provides Australian researchers in all disciplines with competitive advantage through data. So it's got a bit of a global focus about boosting data here. And that goes to what Andrew was talking about before, I think, in terms of actually empowering researchers to use data. That's part of their role. One of their projects is the Health Studies Australian National Data Asset, HASANDA. And this is a health data specific project designed to facilitate the reuse of clinical trials data. So it's currently under development and some of the hubs in disease specific areas are now operating. So it's a slightly different focus here. It's actually about promoting the reuse of research data rather than access to routinely collected health data, but it's still, one of the key elements that we need and that we actually have here operating at the moment. So the Australian Digital Health Agency has responsibility for carriage of the Australian Government's National Digital Health Strategy. The inaugural 5-year strategy and action framework expired at the end of 2022. Consultation on the replacement strategy seems to have petered out. We don't have a new strategy. And the actions in the framework related to research really have failed to materialise. So things really seem to have stalled there. And I think one final piece in the Australian situation at the moment is the Australian Privacy Act is currently about halfway through a multi-stage, multi-year review. So research uses of data is just one of the many elements of the review. Under the current Act, there are some exemptions from the need to obtain consent for the use of data for research in some narrow health-related areas. And they're currently proposing to replace that with a broad consent for research. And the next stage really is consultation on draft legislation. And that pretty much concludes the review of the current context, Nadia.
Greg, look, thanks for that. I know there is more, and thanks for the sort of the whistle-stop tour. I'm going to ask Emeritus Professor Christine Bennett, AO, to jump in here first. I mean, Christine, you brought Andrew here to Australia. What do you see as the potential for an Australian version of Health Data Research UK? And then, Andrew, I'm going to come back to you because I'm keen to know from your perspective what elements of the agency do you think, as you have a broad understanding of our context as well, what elements do you think would work well in Australia? So I'm giving you some thinking time there. Christine, I'm coming to you. There we go.
Nadia, and thanks for doing a great job of leading this conversation. I'm sure the entire audience is totally inspired by hearing what Andrew said, and It gives us great hope that things that we're not sure are possible actually could be possible if we just work together. We've spent the week with CSIRO and New South Wales Health and others, and we do have so many of the building blocks, and certainly I think the motivation to get this done. And this is all happening as part of a thought leadership piece for the Digital Health Cooperative Research Centre, which already has the community, if you like, of supporters that were really what drove the work that the health data research, how it got established. So my hopes are that through connections this week, further connection with Andrew and the team over there, that we and with Research Australia's help as well, we could actually make this similar kind of initiative a reality here in Australia, which would really accelerate not only our research here, but part of a global alliance of such data curators, conveners, to really power health and medical research further.
So thanks for that, Christine. So Andrew, given that it's a bit, it's 5 years on, and I suspect that at least some of the pain has been forgotten. But what do you think we could translate well and quickly into the Australian context, reflecting on your experience?
And I've got so much to learn, and I learn so much when I come to Australia. It's wonderful. And we just remember, we're not there yet. We're in the foothills of where we need to be. But what got us going was joint strategy. And there was actually the inspirational leader who kicked this off is now in Melbourne. He's John Saville. Do you know John?
John Saville, yes, he's very much in the Australian landscape, currently leading one of the Advanced Health Translation Centres in Melbourne.
Yeah, so what is, because he was formerly the chief executive of the Medical Research Council, and what he did one-on-one, one by one, was to go around the other funders and say, look, we're all spending money in this space, it's all subscale, let's get joint strategy. And to have the main logos of both the service providers, the NHS, plus the funders on the same piece of paper to say, we're going to set up a national institute. This is the vision. This is what it's for. These are the benefits. That was the catalyst, really. So I think thinking through, because you've got great stuff here, and to put it simply, if you could get, it's not command and control, it's coordination, connectivity. 2 + 2 would equal 5. And you need to write that down in a vision statement and say, this is what we're, and would be my sense of how to support coherence of the ecosystem.
Question from Janice Besh, because we are going to have to touch on funding and because this doesn't happen by happy coincidence, even with the best will in the world. Yeah. And Janice's question was, did NHS tender for this, or was it a researcher-led proposal? You just mentioned John Saville, but that was in context of him leading a government agency group.
Yeah. So part of this, there's lots of money across the ecosystem. So different things have had. So the research component has 10 funders. We got 50 million. That was renewed just last year. We got 9 out of 10, and they said we were internationally pretty good, and they've increased it to about 78 million. And so they're the research funding agencies. But because we've made progress in what I call the standards, the protocols, the harmonization, the NHS have themselves put 270 million in across England to create. And that's good. The key is that it does any investment support interoperability. So, I talk about the ITIs. So it's security, reliability, sustainability, security, and most importantly, interoperability. So that when you get new investment in, it can plug in nicely and not create another silo. So the money comes from different parts of the system, whether it's public sector, government, industry. The key is interoperability.
So let's touch on the thorny issue then of industry and private companies accessing public data. You know, you said that it was a thorny issue, and it is a thorny issue. And as you say, with the fourth industrial revolution, we're going to see companies such as the Googles and the Amazons and the Microsofts. They already are competing and very interested in the opportunities that health data offers. Where's the how do we ensure balance, and that the public good and public interest side of things is not compromised in the pursuit and the very real and necessary pursuit of these organizations to participate in our health system?
Yeah, so it's a very good question, and we don't have all the answers. Saying that, our research hubs have, I said, about 500 contracts, of which 40% are with industry. So this is, you know, this is happening. There is a commercial framework of how to do business, and there are principles of that. So firstly, no exclusive access to data. Secondly, any collaborative or contract relationship with industry has to have a clear public interest. Thirdly, there has to be a benefit share back to the publics. And that can come in various guises, and we can maybe touch upon that. Fourthly, we've managed to secure a lot of innovation in this space because we involve the publics as well in the decision-making around how industry interacts with data. So there's a sort of packaged approach to how one tries to define trustworthy models of how this happens. And we, you know, as I mentioned, we've got both the big boys like Google, Microsoft, as well as the SMEs as part of the ecosystem. But it's about fair trade, not free trade, if I summarize.
That's a nice way of looking at it. Greg, I'm going to come to you for your question, and then I want to talk about a question that Emmanuel's put about social utilizing benefit from health data.
I was just going to comment on the situation in Australia around that. So that was a hot issue with the Data Availability and Transparency Act. And there were certainly stakeholders arguing that there should be no commercial use of data allowed under that act. And we pushed back on that very hard and said, look, really the test here needed to be a public interest test. And that the question of whether there was commercial use was really quite secondary, and that commercial use would be possible as long as there was still a public interest and a public benefit. And that is where we've landed, because we made the case that, you know, it was very difficult to tell with a lot of this data whether in fact there might be finally a commercial use of it. And so we've successfully, at least for the moment, won that argument in Australia, I think.
I think it's a conversation that will continue on and on and on as the value is both realised and recognised. Staying with matters economic, a question from Emmanuel is, if we have to utilise and benefit from health data the way big IT social media companies do, then we need to pay data scientists enough to lure them to work in this area. So the question, Andrew, for you is, what has HDR UK's experience been with convincing funders and government that remuneration for these professionals is far higher than traditional data managers and conventional data analysts?
That's a good question, and we struggle with this as well. One or two things, as a charity and our own legal entity, we can set our own pay scale. Saying that, you know, master students can walk into jobs in industry at £80,000 a year. It's, you know, completely different ball game to academic or public sector. So we struggle with that. What we do see is, because in that industry sector, people can make a lot of money. So what we've managed to do is identify people who have an altruistic streak and are more senior in their careers, and they sort of come back to us. So we've had 4 or 5 people who've been very, very senior in industry, retired at the age of 40. That's a dream world for me. And then have come back because they see it as altruistic. So there is a challenge, but we're also looking at creative ways to attract talent.
Given, as this is a question by Vlada Razova, traditional academic research tends to be quite slow with data access or without. But I thought this was an interesting one. Would having in-house departments of data scientists in hospitals working specifically on projects that align with strategic interests help speed the take-up of new technology? So do we need to unleash data scientists within health systems?
So my answer to that is yes. So yeah, I think every highly performing health system. If you go to the Mayo Clinic, they have a center for innovation full of data scientists next to the canteen. Same in Vanderbilt, same when I was in Scotland, that's what we set up, and same at Great Ormond Street. Yeah, so it is, you know, and data and technology should not be under the stewardship of the finance director in hospitals, and that's where it tended to be. It has its own clinical impact, but then again, it's our job to convince folk that's the case.
Well, I mean, on that, you've mentioned data literacy, and of course, we've spoken about it from the public side of things. But do you think that we need more training for our clinicians to train them numerically, and just that, given that we're suggesting that more and more clinical practice will be driven by algorithmic, by algorithmic lenses?
Yeah, so a few. I used to be dean of a medical school, and a phrase I used is it's easier to put a person on the moon than change the medical curriculum. Because, but what we did when I was in Edinburgh, we actually put a data science module into the medical curriculum, because actually students expect it. What we've done recently with all 47 medical schools in the UK is do a survey of current delivery of data science, and it's woeful. And I'm actually going back. One of our black interns did the survey wonderfully, and they're going to go and present to the deans to tell them that they're dinosaurs. so I do think, wow. I do think it's, we need this phrase agility, in medical education training, clinical training. We need to embrace these tools because they will make our lives easier.
So a question from Jade Barclay: does data access for public benefit go both ways? So do public institutions get access to routinely collected industry data from sort of, the example is insurance and private imaging?
So to be honest, our industry data sets are not that comprehensive at the moment. So there are some, okay, mostly clinical trials. So most of the imaging data sets are in the public sector. But what I think it's a good question, and the way we would approach it is through a very focused driver project to try to sort of, test some of the assumptions rather than do it in an abstract way.
We've got time for, I don't know where the time's gone, but we've got time for just one more question. Lucy Kleins, you had your hand up, it's down. Nod, blink if you want to take the time for the question. It will be the final question, and then I'm going to invite Annette to say a couple of words.
Thanks, Nadia, and thank you, Andrew, for a fascinating conversation. I'm looking at Jade Barclay's comment here. Who would we bring together to start off a joint strategy like this in Australia? And I'm thinking, Andrew, about your comment earlier that you had about 80 groups signed up to your alliance, which sounds like a good number to me. But I'm interested to know who didn't sign up and where amongst the research system, the health system, from the general public, did you need to do more work building that social license or convincing people that this was the right direction to head in?
Okay, so there's sort of three questions there. So in terms of Australia, there's some fantastic things in Australia, but as a friend, I would say if you've been in the same room to actually, our approach, because part of this is social engineering. So in the early days, I just bought everyone dinner. So we also had things called a frontiers meeting. So host a frontier, a what if meeting to talk about the Institute. Get people in a room and then have dinner with them. And then you start to build, because this is a people project more rather than a technology project. But if I look across Australia, I was at CSIRO, I know Merryn Smith was in London recently about PHRN. I'm conscious of all the stuff they're doing in New South Wales. You know, there's stuff at the Murdoch, Gen, Victoria. There's so much good stuff in Australia. So to pull it into a room, I think would be a fantastic opportunity. There's so much good stuff happening here. In terms of, sorry.
Go ahead.
So in terms of, there's always the naysayers, and we still have naysayers, and it's just part of life. But I think, stick to your values, optimism, and focus on the patient. Well, what's in the interest of the Australian citizens and the Australian patients? Because that will usually guide you to where you want to go. But people do gradually come on board. Our initial group of 80 was 2. It was us and NHS England. And then it grew to Cancer Research UK. And now, I think in a year, we'll probably have 200. So we've sort of got critical mass, because people have now got fear of missing out, which is good. So
an impressive story for sure, Andrew. We have a phrase for the convening here. We call it cat herding. And on that note, I'm going to invite Chief Cat Herder for the day, Associate Professor Annette Schmidi, to say a couple of words in about a minute. Annette.
Thank you, Nadia. Well, I've had the privilege of being with Andrew over the last couple of days. We started in Brisbane on Sunday night. As he said, we've had visits to CSIRO, and we've met with New South Wales Health, and this opportunity today with Research Australia, and this afternoon with the Digital Health CRC. So he's been very generous in making his time available. And it's been, as I said, a privilege to be with him this week. And he's absolutely right. We are doing some wonderful things across this country. The problem is we're not joining it all up. And I think that's the call to action that I'm hearing, having spent the last few days with Andrew, and also in my role at the Digital Health CRC. I mean, I'm sitting here listening, I'm thinking, yes, we've got participants from right across the nation, 60 all in all, every state health department. So we really need to come together and see this as a national challenge. I see this as a call to action. And it is really around seeing data as national infrastructure. And we really have to bring all those elements together to accelerate, the challenge we have, but the benefits at the end of the day are so profound, as we said, at an individual patient level and as a population level. And I think that, that's at the end of the day what this is all about. It's improving the health and the healthcare of all Australians. So on that note, I'd like to thank Research Australia for hosting the webinar today. We've had numbers of people, which is fantastic, and we need to keep the momentum going. And I think that's what's wonderful about the value of bringing the experiences that you've had, Andrew. Very important, and it gives us confidence that it is possible despite the size of the challenge. So again, Nadia, thank you, and all the wonderful staff, Lucy and Greg and Sabrina at Research Australia, for making this happen.
Thank you, Annette. My thanks as well to you, Andrew Morris, for sharing your expertise with us today. We look forward to continuing the conversation. Sarah Erickson from the Digital Health CRC, thank you so much for your role in this. And I thank all of you for joining us today. I bid you a very good afternoon.